Welcome to the NCLEX map. Today we master fluid and electrolyte management at the level where human physiology becomes clinical judgment. Imagine the cell as your patient. Sodium regulates extracellular osmotic tension. Potassium governs repolarization. Calcium stabilizes membranes, and hydrogen ions dictate enzyme function. A nurse who can anticipate ion movement saves lives because electrolyte imbalance kills silently, often without dramatic alarms. Let's test your understanding with real clinical physiology. In this question, a young adult with severe vomiting for 3 days arrives with blood pressure of 90/50, dry mucous membranes, and confusion. The labs show sodium of 128, potassium of 2.9, and serum osmolality low. Which intervention is most appropriate to stabilize the patient? Normal saline bolus, 3% saline, potassium infusion at rapid rate, or oral electrolyte replacement as tolerated? The correct answer is normal saline bolus. The patient has extravascular depletion with hyponatremia due to water excess relative to sodium loss. Rapid correction with hypertonic saline would cause osmotic demyelination. Oral fluids are insufficient for unstable vitals. Potassium should be replaced only after volume is secured because intracellular shift worsens with alkalosis from vomiting. In the next scenario, a patient receiving spironolactone presents with muscle weakness, heart rate 50, and peaked T waves. Which physiologic action explains the correct first intervention? Administer intravenous insulin with glucose. The insulin stimulates sodium-potassium ATPase on skeletal muscle and drives potassium intracellularly, reducing extracellular potassium to avoid cardiac arrest. You do not give sodium bicarbonate first unless profound metabolic acidosis. Electrolyte removes potassium slowly. Dialysis works for anuric or refractory cases. Never wait for a provider when potassium threatens conduction. In this question, a trauma patient loses 2 liters of blood. After aggressive isotonic fluid, the nurse notes worsening crackles, jugular venous distension, and urine output dropping. Which physiologic principle explains this deterioration? The correct answer, fluid overload preventing forward cardiac flow, causing hydrostatic pressure overflow into alveoli, reducing oxygen delivery to tissues and kidneys. The body's catecholamines constrict peripheral beds, shunting blood away from kidneys. This is cardiogenic shock, not hypovolemic shock. Increasing fluids will worsen the situation. Vasopressors and afterload reduction are considered once perfusion is stabilized and pulmonary edema addressed. Consider a patient with SIADH secondary to meningitis. Their sodium is 115, serum osmolality low, urine osmolality high. They are alert, no seizures. Which intervention reflects clinical judgment? The answer is fluid restriction. SIADH causes inappropriate water retention, diluting sodium. Hypertonic saline is reserved for severe neurosymptoms, not stable patients. Salt tablets may support chronic outpatient cases, but do not reverse acute free water excess. Diuretics without restriction perpetuate renal water reabsorption. In this scenario, a marathon runner collapses. Vitals show tachycardia, normal sodium, but potassium 1.9, deep U waves, and skeletal muscle weakness. Why is intravenous potassium replacement with continuous ECG monitoring the priority? During prolonged exertion, aldosterone secretion is elevated. Sweat excretion removes sodium but not potassium proportionally. The kidneys respond by excreting potassium to conserve sodium. Replacing potassium orally is too slow. Rapid IV without monitoring causes lethal arrhythmias. Never push potassium. dilute and infuse. This next question. A septic shock patient receives 2 liters of normal saline. The nurse sees rising chloride and falling bicarbonate. Arterial pH now 7.28. Why should fluids change to balanced crystalloid like lactated ringer or plasma light? Normal saline delivers excessive chloride, producing hyperchloremic acidosis. This reduces renal perfusion and constricts afferent arterioles, worsening acute kidney injury. Balanced fluids mimic plasma electrolytes, lessen acidosis, and improve microvascular flow. This is evidence-based, not preference. Now consider acute pancreatitis. The patient is third spacing, hypotensive, tachycardic, with hematocrit rising. Aggressive early isotonic fluid saves organs. Why not bolus half-normal saline? Hypotonic fluids worsen interstitial edema. Only isotonic solutions restore intravascular pressure, reduce hemoconcentration, and prevent necrosis. Lactated ringer also buffers acidosis and improves outcomes. If this has helped you, subscribe and keep learning with NCLEX-map.